Hi, everyone, and welcome, and thank you, Dr. Khan, for the introduction. I'll share my screen very briefly. So the aim is to go through three cases per candidate. We'll get through them um, sequentially. One of the things that certainly came from my experience of going through the FRCR 2B examinations is this quote or this standard of saying, typical presentations of atypical things or atypical presentations of typical things. And I'll be focusing on that as we go through the cases I'm presenting to you. As Dr. Khan said, most of the cases will be GI related, but some won't be. So for the candidates who will be answering the questions, please don't become obsessed with looking for a GI cause for everything. Um, and the other thing I just want to kind of touch on is some of these cases may be a little more challenging. It's intentional, and it's really a conversation, and the 2B examination often is a conversation. And the final thing to say is I'll give you mouse control. The monitor that has the cases on is over to my right-hand side. So I might be looking elsewhere. I'm not distracted. I'm looking at what you're doing, but won't be looking at the camera. So allow me to share my screen. Okay. Can you see my screen clearly?
Yes, sir, I can.
Wonderful. And do you want to request mouse control?
Yes, requested.
Fantastic. Give me 2 seconds. Apologies. Okay, do you have mouse control now?
I'm trying to scroll. Yes.
Yeah, perfect. Looks like it's working. Okay, so let's commence. This is a gentleman who's presented with confusion, and it's just a CT head. Don't worry about the thumbnails on the side of the screen. Um, I'll just take the mouse for a second. You can change and window by clicking on the button at the top. There, there, if you need to. And otherwise you can scroll accordingly. So go ahead, talk me through this
Okay.
case.
Okay, so I'm presented with CT scan of a gentleman presenting with headache. I would like to have a general look before starting my comments. The CT is axial cuts without contrast. So there is a small hypodensity seen on the right periventricular region, could be representing a lacunar infarct. And there is a hypodensity seen in the region of the brainstem and the pons, with a suspected hypodense lesion. There is no intra or extraaxial collision. There is no hydrocephalus, midline shift, or mass effect. So, no areas of bleed. Given the clinical presentation and the radiological feature, I'm concerned, and the age, and this hypodensity over here could be representing a, it's unlikely to be infarction or.
Why'd you say that?
Okay, so yes, this hypodensity should be involving, to be an infarction, it should be involving the cortex as well as the medulla. Yes, it is extending into the cortex of the medulla, to the surface of the medulla, so it could be an infarct. So I would like to correlate with the post-contrast or with the MRI.
Okay, thank you. I'm just going to take control of the mouse for a moment.
Okay.
So you've requested a post contrast, and there you are. Could you just take me through the post contrast brain, please?
Okay, so this is the CT for the same patient with contrast. This is the most uppercut going down. And this is the area of concern. So no masses could be identified. And the cerebral vessels are well opacified. I couldn't appreciate an abnormal enhancement in the region of the pons. However, there is. Okay, 1 minute, please. The venous sinuses are well opacified.
Okay, and
So,
if I just take control of the mouse just for a moment, and I ask you to look at areas like this, and I'll go down areas like this.
okay.
Just talk me through what you think those might be and how that might change your differential.
Okay, so small ring enhancing lesions, 2 of them on the right cerebral hemisphere. This carries the possibility of infectious process like
Okay.
neurocysticercosis. Other possibilities could be brain masses, metastasis,
Okay.
or it could be all the infarctions, yes, acute infarction. They are enhancing as well,
They
ring
can be,
enhancing
can't they?
lesions.
Yeah.
Okay, so more possibilities that could be however, MS, yes, active plaques. So better to go for MRI for further characterization of these lesions.
Other investigation might follow this apart from an MRI. You mentioned one of your differentials was metastases. What else might you do in that scenario?
Okay, so in when I'm suspecting metastasis, then I should be looking for the bone window to complete the study, looking for any bone lesions
Okay.
to
There's no
correlate to the
bone.
patient's history.
There's no bone
Correlate to,
lesions.
okay, correlate to the patient's history if any non-primary neoplasm. CT scan of the abdomen, chest, and pelvis to look for any primary.
Yeah, good, great. So let's just flick open that case. Take me through
Okay.
that.
Okay, so this is the CT of the chest for the same patient with IV contrast. I would like to scroll through the whole stack of images before giving my comments. Okay, so this is the last cut. I'm interested in the chest. Going through the abdomen, there is no ascites, there is no peritoneal thickening, no caking. I couldn't appreciate retroperitoneal lymphadenopathy. The liver is non-cirrhotic with no focal lesion, and the adrenals are unremarkable. The spleen is all unremarkable. There is abnormal soft tissue lesion with central cystic component representing necrosis with peripheral enhancement seen on the left upper lobe, abetting the mediastinum and the aorta. There is reduced left volume of the left hemothorax. Sorry, I'm just having an issue with the scrolling. I would like to
Oh,
go down.
sorry.
Yes. Okay, so yes, there is reduced volume of the left hemothorax. And so I'm
Just
searching
have a
for any lymphadenopathy.
Good.
There is no
Just
mediastinal or high lymphadenopathy. I would like to check for the pulmonary vasculature. I'm suspecting bone lesion on the scapula on the right side, destructive.
very
So I
good.
would like to check this on the bone window.
Okay.
Regarding the reduced left lung volume, I'm suspecting element of airway obstruction causing this reduction of the volume. I would like to check the airways, which is better to be done on the lung window. I would like to check the lungs on the lung window, please.
So just pause on that for a second and
Okay.
try to give me a unifying diagnosis between everything that you've seen.
Okay, so this is a neoplastic process, most likely. The necrotic lesion over here, this could be a necrotic lymph node or could be a squamous cell carcinoma that undergoes necrosis or non-small cell lung cancer, giving metastasis to the bone on the right scapula and to the brain. I would like to complete the study by checking the lung window, by checking the bone window, and I would like to manage this patient by conveying the finding to the referring doctor, refer the patient to the oncology MDT for image-guided biopsy, histopathology, and to be managed accordingly.
Brilliant. I think that's an absolutely brilliant run through. Um, Very nice and clear. One of the things, again, from my observation of the 2B, is that what they want to have is a sensible train of thought. And even if you don't, and in case of the post-contrast brain, I'll take you through the imaging in a second, you didn't immediately see those metastases. But I think most examiners realize that in an exam situation, you're not reviewing it at the pace and rigor that you would in real life. And what they want to see is a sensible chain of thought. And I thought you did that very well. Well done. So,
Thank you.
um, first thing I showed you was the CT brain, and I think you did very well in spotting these areas of mild hyperdensity. Um, just talk me through what the difference is, and I think it's very difficult in this case, but how do you determine the difference between a metastasis and an infarct regarding the edema? Talk me through that.
Okay, so in cases of metastases, it will be likely multiple, involving supra and
Yes.
infratentorial spaces and surrounded by edema, showing enhancement, solid
And the
components.
characteristic of that edema is what?
Okay, it would be vasogenic.
Good. And vasogenic edema versus neurogenic edema? What is the characteristic defining difference in the imaging appearances of vasogenic versus the
Okay,
alternative?
vasogenic edema is finger-like following the white matter. It doesn't disrupt the blood-brain barrier. The
And also,
cyto
it spares the cortex, right?
yes,
And that's the fundamental difference. And so if you
yes,
can see a cortical stripe overlying the edema, you can be more sure of it being vasogenic and more likely then to be something like a metastasis or something that is inherently different to the brain tissue that shouldn't be there, unlike something like an infarct or multiple sclerosis. Um, okay, so if I were to describe this, I'd say exactly as you started, non-contrast CT brain, um, and there are multifocal areas of low density scattered through the brain on both sides, both in the supra and infratentorial spaces. Um, And then I would talk about trying to define that in a bit more detail. These are located in multiple regions. I'm looking to see if there is cortical sparing or not, as this would help me determine if there is an underlying cause, which is likely either vasogenic or neurogenic. Um, and then exactly as you said, I would go on to talk about alternative things elsewhere in the brain, elsewhere in your brain and on that brain to try and talk the examiner through your thought process. And so as you're scrolling through, I can't see that there's any evidence of significant hydrocephalus. There's generalized volume loss throughout the brain. There's no obvious hyperdense vessel sign. There's no intra or extraaxial hemorrhages, and there's no collections. I'd like to look at the bones, and probably what the examiner would do is say, don't worry about that. What would you like to do next? And you came up with two very sensible suggestions, which were an MRI and a CT. And if we go back to the CT, post-contrast, it's one of those cases where the more you see, the more metastases you can kind of spot dotted around all over the place. Like I said to you at the outset, this is a hard case, but the intentionality here is another one up here.
Okay.
Um,
Yes.
It's a hard case, but the intentionality is not necessarily about finding the images, but it's a storytelling piece. And rightly so, you said what the differential is, and you suggested a safe suggestion of a CT tap. One of the things I liked about what you did is to say, I'm going to review the whole examination, and you went all the way down to the bottom. Please always do that. It's a really good thing to do. What I frequently used to see was people concentrating on these first 5 slices at the top and miss the gaping problem down at the bottom. So very quick flick through, and that should help you decide what you're going to focus on. So in this case, I would do exactly as you say. This is a CT, chest, abdomen, and pelvis. It appears to be in a portal venous phase examination. And I started to, as I'm rolling through the chest or scrolling through the chest, I see there's an abnormality in the left side of the chest, involving predominantly the chest wall. There's no large pleural effusions or pericardial effusions. Scrolling down to the bottom, I see a renal cyst, there's aortovascular disease, can't see any large liver metastases. And the prostate looks a bit big. So the biggest abnormality that I saw as I scrolled through on very quick review was the thoracic finding. So I'll concentrate on that. And if the examiner at that point wants you to concentrate on something else, they'll direct you typically. They don't really want you talking about the thing that's not relevant. So they tend to move you on if it's
Okay.
not. One of the things, again, that I'd say you did exceptionally well, I think that's quite a hard spot, that scapula, when you're looking on soft tissue windows. So very well done on spotting that. And it does change the differential because some of this, you might argue, could be a horrible infection. And then the brain stuff could also be a bit of an infection, multiple abscesses. But I think once you start seeing the shoulder, you move into metastases, don't you? You move into primary lung cancer, metastatic deposit within the scapula and in the brain. Well done. Okay, let's move on to the next case. Okay, you can take over mouse control again. And the history is abdominal pain, query cause.
Okay. So I'm presented with CT scan of the abdomen and the pelvis for a patient presenting with abdominal pain. I would like to have a general look before conveying my findings. So the study is done with IV contrast. And as I go through the images, I couldn't appreciate any bowel obstruction. There is no ascites, no omental thickening. The hernial orifices are intact. So I would like to go systematically in this study as I couldn't appreciate any abnormality on my first view. There is a right adnexal cyst with peripheral enhancement or calcification, which I would like to verify with silver plane study.
Do you think that's enhancement or calcification?
Pardon me?
Do you think that enhancement or calcification?
Seems calcification, very dense, peripheral, following the bone density.
Okay.
So it's likely a calcified right adnexal cyst. Other than that, it's not associated with surrounding fat stranding or collection. There are no significant lymphadenopathy on the pelvis. So rest of the scan, patient presenting with abdominal pain.
Let us focus on that cystic entity in the right lower quadrant.
Okay. So going down.
Talk to me a little bit about it, describe in a bit more detail, and tell me what your differential might be.
Okay. So the cyst is seen on the right side of the pelvis, in close proximity to the uterus. It is well defined with essential area of calcification and as well as peripheral calcification. It is not surrounded with mesenteric fat stranding, and it is not showing soft tissue, enhancing soft tissue component or nodules. I think it's originating from the right adnexa. I would like to check for the left ovary. It is indenting the urinary bladder gently. Okay, sorry, again, scrolling issue. So
No
going up,
worries.
again, calcified lesion seen at the site of the left adnexa.
Just point that out to me, sorry. The left adnexal
Okay.
calcified lesion.
Okay. Right. Over here. Here.
Okay.
Okay. So this lesion is cystic with peripheral calcification. I will go with mucinous ovarian conditions. And I think, yes, I think this is related to the bowel. These are diverticuli. So I couldn't appreciate any signs of malignancy on this CT. I mean, there is no signs of invasion to nearby structures. There are no regional lymphadenopathy, and it is not causing significant mass effect to the nearby structures. So I would like to check this on the coronal to further evaluate the pelvic organs or the sagittal, if available.
Okay. You can have a look at the coronal. There you are.
Should I drag? Okay, come on. Okay, yes. So the lesion is actually elongated and seen adjacent to the uterine corner. It could be representing a fallopian tube rather than an ovary. So again, there is no internal enhancing soft tissue component. I think this is another calcification. So my thinking is about hydrosalvage, or could be still an ovary. So I would like to correlate with the patient's history if she's having any infertility or any previous history of pelvic inflammatory disease that might cause this tube to block and to distend and to fill with fluid, and would like to correlate with the, any other previous ultrasound images if available.
Okay. And I'm just going to bring up the axial again, and I just want to add an additional finding to the clinical history provided to you. The patient's also suffering from right leg swelling and pain.
Okay, right leg swelling and pain. So I should be looking for the vessels to exclude DVT as the main cause of limb swelling and pain. I would like to follow the common femoral vein. which is not showing filling defect.
Okay.
Okay, there is no hernia. And the muscles and the fat planes on the right side appear unremarkable. So, right back pain and swelling. In a patient with pelvic cystic, okay, there is a filling defect in the right common femoral, right common iliac vein. So the patient is having DVT. This is an emergency to be urgently conveyed to the referring doctor to start thrombolysis.
Good. Very well done. I'll take mouse control again. Again, a lovely description. I realize these are thin images, so it takes a while to scroll. Your finger must be tired, and I apologize. Again, I think you did a good job explaining and talking me through. So you explained what I was looking at. You gave me confidence that you gave me confidence that you knew what you were looking at. Explained it was a post-contrast scan. You didn't immediately identify the abnormality, but you came back up and you saw it then. You, however, jumped to the suspicion, or you immediately called this an adnexal cyst. And the adnexal cyst is broadly a byproduct of an ovarian cyst or a fallopian tube abnormality. And always be cautious of cystic structures, particularly down in the bottom right-hand corner of the abdomen. So this was actually an appendiceal mucocele. And if you look at the appendix, so this is cecum, appendix coming across, coming over, and it goes into this structure, which then, exactly as you identified on the coronal, is actually long and almost tubular in its shape, which I thought was actually quite intelligent of you to then go on to say, this might be fallopian. It's unusual, however, to have mucinous fallopian lesions. In fact, fallopian malignancies are actually pretty rare and typically present late with widespread disseminated peritoneal disease by the time they present. They don't typically get calcified mucinous lesions or calcified cystic lesions like this within the fallopian tubes. So the learning point here is cystic tubular type structures anywhere in the bottom right quadrant. Always question where the appendix. So what you should do is look for the appendix actively. Now, just as a quick tip, people sometimes get confused looking at the bowel in the bottom right corner of the tummy. And a very, very quick way of identifying where the cecum is identifying where the ileocecal valve is. And a very quick way of identifying where the ileocecal valve is the blob of fat. It takes seconds and is nearly always there. It's quite unusual to have a completely fatless ileocecal valve. So when you see this is always the valve. Go up and go down. One of them will be a blind ending bit. That's your cecum. Then you can find the appendix off of that. Despite that, it can be quite hard to find an appendix in two main reasons. One, they've had an appendicectomy and the appendix has been chopped out. And two, is typically in older patients, the appendix can become quite atretic, very difficult to see. But in this case, you see ileocecal valve. We can go this way up the valve. Where does that take us? Well, that takes us to the ascending colon, so that's not the right way. Back to the valve, let's go downward of the valve. That takes us this way. Oh, that's blind ending. Where's the appendix? Here it is. So it's a really quick, robust strategy but always finding the appendix.
Okay.
So appendiceal mucoceles typically have calcium in them, typically dilated, typically low density. Another kind of phraseology that people might use for this is an LAMN, a low-grade appendiceal mucinous neoplasm. Um, these can exist sometimes quite indolently, and by that I mean you might see them incidentally in a patient for another reason. The patient's pain has almost certainly nothing to do with this, but they are either malignant or pre-malignant and do need resecting to reduce the chance of disseminated malignancy. Where they do disseminate, do you know the type of ascites that this might predispose to?
Yes, they give the pseudomyxoma peritonei,
Good. What might that look like on imaging?
indentation to the liver and spleen surfaces.
Yeah, great. So you end up with this ascites that's loculated, much like you can imagine this. This is loculated inside. You can kind of see these internal complexity, right? Same thing
Yes.
happens elsewhere, and those loculations result in those local bits of mass effect on structures. It's a very odd thing when you see it, but it's an art mini, and by that I mean when you see it, it's quite obvious what it is. And then you go hunting for the appendix, and then you go hunting for the ovary.
Okay.
Well done. Uh, Last case. Um, yeah, just talk me through what you see first on this sequence.
Okay. So I'm presented with MRI axial cuts. This is T2 of the abdomen for a patient, to which I would like to check the whole stack of images. This is the last cut. So going up again, I can see that the liver is markedly hypointense on this T2 study. The spleen retains normal signal intensity. The heart also seems normal, and the bone marrow as well shows normal signal intensity. So I'm suspecting a deposition disease on the liver that causes this appearance. I'm suspecting hemochromatosis, mitodifferential. So thinking of this, I would be looking for the complications of hemochromatosis, which is liver cirrhosis. The liver appears small in size with lobulated borders. Would like to check for the other stigmata like hypertrophy of the left lobe and leukoidal lobe, which I can see. Other associations are actually caudal lobe is not so much enlarged, sorry. The portal vein shows normal signal void. Checking for the any liver masses that are associated with this condition, I can see that there are multiple hyperintense foci distributed on the right and left hepatic lobe with hypointense rim.
Okay,
There is
let
no
me
biliary
just,
ductal dilatation. Yes.
I'm just going to take the mouse over and switch you over to the diffusion. If you want to have a quick flicker through that.
Okay, so this is the diffusion, and the previously mentioned lesions show bright signal on this diffusion. I would like to correlate with the ADC, please.
No ADC, but why don't you have a look at the, sorry, I'm going to take control of the mouse again. Why don't you have a look at the arterial phase? Yeah.
Okay, so this is the arterial phase, and the lesions are non-enhancing on the arterial. Okay.
Talk me through what you think about the quality of this arterial phase.
The quality of the arterial phase.
Yeah.
Okay, so this is the early arterial, as I can only see the cortex of the kidneys.
Hmm. What else should you see on or what else would you see on an early arterial as opposed to a kind of parenchymal arterial phase?
Would you kindly repeat the question?
What else? How else do you differentiate? You regarded this as an early arterial phase. What else, what other differences would you regard or would you see if this was a parenchymal arterial phase?
Okay, usually on the early arterial phase, the spleen shows the zebra lines. Here it is homogeneous. So this is most likely a bit later phase of the arterial phase. The liver also is enhancing, so it could be like late arterial phase.
Okay, and then I'm going to take over the control again, and I'm just going to give you a very quick, just in the interest of time. This is the portal venous phase. If you just observe, you don't need to comment. I'm just going to take you through that again very quickly. And then
Okay, yes, so
finally, I'm going to give you this phase of examination. So take me through this.
okay, okay. So I can see that there are multiple irregular liver lesions involving segment 7 and segment 4A of the liver subcapsular with peripheral enhancement and central areas of non-enhancement. Another lesion seen on segment 2. These lesions, they are numerous, distributed on both lobes. So my differential, given this appearance, and this is the late arterial, so there is central washout, and there is capsular retention of the contrast. Possibilities would be multiple HCCs, or could be multiple metastases. Unlikely to be hemangiomas because they show centripetal filling, which is not the case. Unlikely to be FNH because I would expect the to be iso-intense on the portovenous and delayed phases. Unlikely to be adenomas because these are showing transient avid enhancement, which is not the case. Other possibility, the liver is cirrhotic. So yes, my strong differential is multifocal HCCs. So I would like to compare with previous, correlate with the patient's history for any high levels of alpha-fetoprotein and advise for image-guided biopsy. Or if we proceed for the primo-VIST scan, then these are not going to show uptake, and this will be like satisfactory given the liver cirrhosis and the clinical presentation. Then I would like to refer the patient for the hepatobiliary team for further management and follow-up staging, CT chest, abdomen, pelvis, and
Okay.
follow-up.
You mentioned a Primavist scan. How would you tell if a scan is a Primavist scan or an intracellular contrast scan? Sorry, an
Okay,
extracellular
so
contrast scan, pardon me.
okay, so timing would help. Usually, Primovist is done like for 1 hour later. The
Okay.
early phase of Primovist is like usual phase because it acts like extracellular. Then it becomes to concentrate on the lesion that contains hepatocytes. And finally, it is excreted by the diminuted biliary tree.
Okay. Good. Okay. So let's run through this case. Well done. Um, so I would have personally been petrified if you showed me an MRI liver for my 2Bs. I think you did well. Uh, remember, typical presentation of atypical things or atypical presentation of typical things. Um, generally, if they're going to pick a slightly weird or wacky modality, like a post-contrast MRI liver, you're going to get something that's probably relatively simple. And some of the questions certainly I was posing to you, I was purposefully pushing you for the higher score marks. So let's just go through this. You were right. This is a T2 examination through the upper abdomen. I think you jumped ahead quite far. It's quite a stretch to say this is hemosiderosis or hemochromatosis on the back of an of a T2 rated examination alone. I do get your point, though. The liver is a little bit dark, and that would make me look at the chemical shift imaging to look at the in and out of phase sequences to determine if there was any deposition disorder. In this case, there actually isn't. And one of the things that you'll experience as you spend more and more time looking at these MRs is that different scanners have quite different appearances. So a T2 on one scanner is not the same as a T2 on another. And in this case, the chemical shift imaging was totally normal. You're right, though, the patient did have cirrhosis. And what I would have expected is someone to say there are some high signal intensity, well-defined foci. These look like hemangioma or cysts. The spleen is a bit big. There's no biliary tree dilatation. The liver has a slightly irregular margin and mild, maybe central atrophy. Beyond that, I don't think you're going to really say much else about the liver. If you manage, though, to pick up on these areas, you can see that posteriorly in the right lobe, there are these areas of ill-defined T2 hyperintensity. I'd have been impressed, but certainly not obvious on a quick run-through of the liver. There's another one here, just for interest. I then showed you the diffusion-weighted imaging, and again, super subtle. You spotted this area here within the left lobe. The area within the right lobe is altogether more subtle. I think some of this is just artifact related rather than truly being lesional. But you did the right thing. You spotted it, you described it, and you said you'd like the ADC map. On the arterial phase examination, you started off strong with my quizzing you of what a good arterial phase is, and then I think you kind of back trod a bit. I was again polling you quite hard, questioning you quite hard because I was purposely trying to see if I could get you those higher marks in the exam. So, an arterial phase examination in the liver should ideally be a parenchymal phase, not an early arterial vascular phase. The way you differentiate this is on a parenchymal phase. The portal vein will contain contrast, but the hepatic veins will not. So just to reiterate, a good parenchymal arterial phase for the liver, either on CT or MR, the portal vein should be enhanced, but the hepatic vein should not. That's actually quite a well-defined thing. If you look at LIRADS, which is the American College of Radiologists' way of determining or describing liver cancer, hepatocellular carcinoma in particular, it makes that as a specific point that we look at the parenchymal
Would you
arterial
kindly
phase.
repeat this again?
Yes, so parenchymal arterial phase should be portal vein enhanced, but hepatic vein not enhanced.
Okay.
Yeah. So if you can imagine, it's gone through the arterial tree, it's gone through uh, the mesentery, through the SMV, up into the portal vein, and at that point, that's an arterial phase. It shouldn't yet have gone through the liver and into the hepatic veins because that would make it a portal venous phase. Yeah. The portal venous
Okay.
phase, ironically, should have contrast in the portal vein and the hepatic veins. And a parenchymal arterial phase should have homogeneous contrast in the portal vein as well, but not yet in the hepatic veins. LIRADS from the American College of Radiology defines that quite clearly. And the reason why this is really important is that for gastrointestinal imaging, it's very difficult to determine if a lesion has true arterial enhancement or not, unless you're looking at the correct phase. So, a hepatocellular carcinoma is one of the few cancers in the body that you can truly diagnose without a biopsy. There is an increasing modern trend now to biopsy HCCs, mainly for genotyping. But actually, for most of my career, we diagnose a HCC and treat a HCC without any tissue diagnosis. I think it's the only cancer that you can do that for. So the diagnosis then must be highly, highly sensitive and highly specific. Obviously, we're going to start treating these things on the basis of imaging alone. It's quite an unusual thing to do for radiology, right? We normally take tissue biopsies. Um, so to do that, you need to be very, very sure about what you're looking at. And as a result, LIRADS is a fantastic, fantastic document on HCC in terms of very clearly defining what is and what isn't. And for those of you interested in GI, I'd strongly recommend it as a really great resource just to read and understand liver MR in a great deal of detail. So arterial phase, this is slightly early, so there's a lack of arterial phase enhancement in any of those lesions. But I would go on to say, but this is a slightly early phase, and it may be that those lesions haven't yet enhanced because of the phase of the study, rather than because they are not truly arterially enhancing. We then go through and there's a portal venous phase, a slightly delayed phase at 2 minutes, and then a 20-minute scan. And on this phase, there is contrast. So Primavist studies, you were right. Primavist studies, there is a delayed acquisition. The delayed acquisition is typically at 20 to 25 minutes, not quite an hour. You can do much more delayed Primavist examinations, but by the time you get to an hour, nearly all of the contrast will be in the biliary excretory phase. Very little will be intracellular in the liver parenchyma. So Primavist delayed is about 20, 25 minutes. Extracellular contrast delayed is about 5 to 10 minutes. You rarely do anything beyond that. So in this case, we see that there's a 20-minute delayed phase study. This is a Primavist study. The alternative way that you can look for a Primavist study, if you didn't know the timing, is that you'll see the liver will be bright, the vessels will be dark, and there will be contrast in the biliary tree.
Yes. Yes.
So this is now excreted into the biliary tree and actually is heading into the duodenum. Primavist is also excreted by the renal tract, which is why you're seeing it in the kidneys here.
Okay.
There's one caveat to that. It's something I published on a while ago, which is in patients who have severe liver disease. By that, I mean broadly acute liver failure. Their livers are not processing or uptaking the contrast at the same rate that your liver or my liver would. And so at the 25-minute scan, you may end up with something that looks more like a portal venous phase, something like that. Contrast still hanging around the blood vessels, no contrast in the biliary excretory system because it's not yet passed through the hepatocytes and into the biliary system because the hepatocytes aren't working. So it's a caveat. You're not going to get it in your exam, but I thought I'd mention it. So let's now very quickly just talk about the lesions. The intentionality again of this scan was not to get you to diagnose the lesions correctly. Doesn't matter. It's to look through a logical methodology in your head of how you go through these examinations. So these are actually atypical FNHs, so focal nodular hyperplasia, and they're atypical. So a typical FNH would show a scar, typically hyper intense on the T2 weighted image, and a delayed post-contrast enhancement with extracellular contrast. With Primavist, something completely different. It would typically be iso-intense on most of the phases. So FNHs, pathologically, are very similar to normal hepatocytes. They're just disordered. The way to best perceive them is disordered normal hepatocytes. So they look like the liver on nearly all of the sequences. You may see a bit of arterial enhancement. You may see a centrally enhancing scar that's mildly bright on T2 weighted sequences, but they're quite difficult to see in honesty, in truth. But the thing that you would see on on the delayed hepatobiliary phase examination is post-contrast retention. So in this case, you can see these bright lesions, and these are hepatocytes uptaking the contrast. And because they're disordered, they retain the contrast a bit more than the adjacent parenchyma. Their normal architecture is disturbed, and so they maintain and persist the primavist more than the adjacent parenchyma. The central bits are probably scar. Again, if you look at the T2 weighted image, very difficult to determine scar. So atypical FNH, to reiterate, the intentionality is not to get the diagnosis right. It's a difficult diagnosis. The intentionality is to talk me through a liver MR, a systematic approach of thinking about things, understanding the different contrasts in terms of primavist and extracellular and phase of contrast. So well done.
Thank you so
Okay,
much, Dr. Thank
you're
you.
very welcome. Candidate 2.
Good evening, sir. I'm candidate 2.
Lovely. So candidate 1, can you stop requesting control of my screen?
Okay.
And then candidate 2, could you request, please?
Sure, sir.
Okay, so I think candidate 2, you have control. So let's start. This is a patient who was referred for a CT thorax following an abnormal chest X-ray.
Right, sir. I'm sorry. I'm trying to. Oh, I'm sorry.
Let me take back over.
Yes, I'm sorry. Yeah, sure.
No, not at all, not at all. So I think if you use your
I'm
scrolling
trying
wheel,
with the arrows.
if not, try that now with your mouse. I don't think arrows would work. I think you have to use your mouse.
I'm on my laptop, and I haven't connected a mouse with it. I've got the arrow keys. Sir, can you give me a moment? You can go to the candidate 3, and meanwhile, I'll connect the mouse with it so that we don't waste any time.
It's a good idea. So candidate 3, are you available?
Yes, sir. I'm there.
Would you mind taking over mouse control?
Yes,
We'll
sir.
move
I
to
will.
candidate 3 for the whole pack, and then
Yes, sir.
fantastic. Confirm. Okay.
Okay.
Um,
Next one.
yeah, you can. Should be able to
Okay.
scroll.
Uh,
Yeah, super.
yeah,
Well
yeah,
done.
yeah.
So
Okay.
just to remind you of the clinical history, this is a patient who had an abnormal chest X-ray and is having a CT scan of their chest for further evaluation.
Okay. So I've been presented with cross-sectional post-contrast images, mediastinal window of a patient who has had an abnormal chest X-ray and he's being further evaluated uh, with a CT scan. I'm just trying to scroll. It's taking a lot of time, so okay. I am scrolling with a mouse, but it is still taking a lot of time. So can I use the down arrow?
Try with the arrows. I'm not sure. The because it's mouse control that you have, not keyboard control.
Mm, I'm trying, so it's actually jumping the images.
It's smooth on my side. I can scroll for you.
Oh, yes, sir, that would be great.
Okay, all
I'm
right. Let me
actually
take
trying to
back.
use my mouse. Yeah. Okay, sir.
Let me take back over the mouse control. Okay, so I'm going to go slowly just so you can see. So
Yes, sir.
talk me through what you're seeing as you see it, and tell me if you want me to stop.
Okay. So I've been presented with post-contrast axial images, mediastinal window of a patient. So I'm just, I would initially just go to the last cut before I start commenting.
Okay.
Yeah. Okay. Uh, okay. So on the last cuts, I can see that there was evidence of pneumobilia noted within the liver. On
Mhm.
the initial scroll, I was also able to visualize that there was a subcarinal lymph node noted. Rest of the lung parenchyma appeared relatively normal. So I would just like to scroll again.
Okay.
First, I would like to focus on the liver pathology because there is something abnormal.
Okay.
So I would like to look at the gallbladder initially to see if the gallbladder is contracted or it appears normal. So I can
Okay.
see that there's evidence of cholecystectomy clips noted, probably.
Okay.
Not sure. Yeah, most probably the gallbladder, there's post-operative. So the okay, there also appears to be I'm trying to just focus on the can I go a bit down, sir?
Yeah,
Yeah.
sure.
There is on these images, I can also see that there is appears to be an heterogeneously enhancing area noted in the region of the uh, common hepatic duct out here.
Okay, good.
Yes, sir.
Talk to me a bit about talk to me a bit more about that.
Okay, so that could be a lesion, lesion at the common hepatic duct. But I'm just trying to look at any yes, there is an heterogeneously enhancing lesion noted in the region of Klatskin tube, in the region of the common hepatic duct. There is also central as well as peripheral intrahepatic biliary radical dilatation. The pneumobilia noted within the on the left side could be post-procedural. So I'm just trying to look for any stent, if there,
No, no
that could be a
stents.
possibility.
Okay.
There's no stent.
No.
Okay. Uh, Based on this is an aggressive lesion within the liver, which is causing intrahepatic biliary radical dilatation. So I'm just trying to look for any lymph nodes in the periportal region, which could be metastatic. Uh, I'm trying to look for any capsular attraction.
Mhm.
Uh, Also, in this case, I would like to look at the other phases to look for portal vein thrombosis or there are multiple simple cysts noted in the kidney.
So
Uh,
just as a reminder, this is a gentleman who presented with an abnormal chest X-ray.
okay, okay. So I would like to go up after to look for any lesions within the lung parenchyma. On the initial scroll, I was not able to visualize any large lesions, but I could see a enlarged subcarinal lymph node,
Mhm.
also a pretracheal lymph node. So I would like to look at the lung window images, which could probably show me some small pulmonary nodules, if any. Okay, so on the lung window images, I'm able to visualize that there are paraseptal and pa paraseptal as well as centriacinar emphysematous changes noted in the bilateral upper lobes. Uh, I'm trying to look for any lesion within the lung parenchyma, because there are severe emphysematous changes. There is a very high possibility that this person is a smoker, and there could be a mass. On the lower sections, I can see that there is evidence of interstitial thickening, honeycombing noted in the basal regions, also ground glass opacities and traction bronchiectasis. So there are multiple findings in this uh, lungs. There is predominant emphysematous changes noted in the upper lobes and predominant fibrosis noted in the lower lobe.
Okay.
So this could be a
If you could summarize the case for me, please.
yes. So on the lung window images, I could see that there is emphysematous changes noted in the upper lobe and usual interstitial pulmonary fibrotic changes noted in the lower lobe, which could be a combined pathology of a combined emphysematous fibrosis disease. As well as additionally, I was also able to visualize heterogeneous lesion in the region of porta hepatis, at the hepatic duct confluence with with the intrahepatic biliary radical dilatation. So this needs to be further discussed in the oncology MDT. I would like to look at the first. I would like to look at the previous imaging, because this patient would surely have some previous imaging for the hepatic pathology. So I would like to compare with those. And further, I would like to discuss this patient in the chest as well as oncology MDT.
Okay, let's go through that together. So I appreciate it's quite challenging if you're not scrolling yourself.
Yes.
Maybe we can try the next case. We could try scrolling again. So I like the way that you started explaining what you were looking at. Worth not repeating exactly what I have said. So in this scenario, I said, this is a patient who's had a chest CT as a result of a normal X-ray, an abnormal chest X-ray, and I think you said the same thing. I'm sure it was nervous waffle, but just keep it nice and brief. Your introduction can be quite quick. It is an axial CT examination through the thorax in an arterial phase. That's it. That's all you need to say. As you scrolled down then, I think you very quickly and accurately identified there was some mediastinal lymph nodes, subcarinal, pretracheal, and then you went down and then we got to the abdomen. And you very quickly and accurately identified there's a problem in the liver. Spot on. And that actually was the kind of almost the hard part of this scan. But what's best then to do, just quickly say that you've seen it. I've noted there's also an abnormality in the liver. I'm going to formally or more accurately or more specifically assess the chest. After all, this is a chest CT, right? The purpose of this examination is to evaluate the abnormality on the X-ray. Shouldn't get sideswiped or distracted by things we see over the side. So it's important to, someone's moving their mouse. Would you mind keeping your mouse still? Thank you. Important to focus on the thing that's being asked. Now, in the exam, if they wish you to then forget the chest and talk about the liver, they will push you in that direction. Great. But don't allow yourself to be distracted by these superfluous findings, at least initially. So I would have said, this is an axial post-contrast CT scan of the thorax. I have mediastinal windows and chest windows available to review. Scrolling down, I see that there's some mediastinal lymph nodes, particularly in the pretracheal and subcarinal location. See no large pleural effusions or pericardial effusions. Scrolling down to the bottom of the chest, I see the upper abdominal structures, and it's an aerobilia and there's an abnormality within the right lobe of the liver just here. I'll come back to that once I've more formally assessed the thorax. Then I would go back up to the top and spend some time. So I've seen those nodes. So I would say something along the lines of, given the fact that I've seen some pretracheal and subcarinal nodes, I'm going to increase my search strategy for lymph nodes elsewhere, particularly within a supraclavicular space, the axillary space, the right paratracheal space. And actually, there are some nodes in the anterior mediastinum. Sorry, someone's taking my mouse again. Please, can you not move the mouse whilst you have control? Thank you. And I'm looking at the internal mammary distribution. I can't see any nodes here. I see, again, just there are no pleural or pericardial effusions. Just windowing down to look at the central vessels, there's no large pulmonary embolus within the central part of the vascular tree that I see. I'd like to look at the lung windows. Looking at the lung windows, there is extensive emphysematous change distributed through both lungs. Given the distribution, suggests moderate to severe emphysema with likely the sequelae of smoking history. I see no large areas of collapse or consolidation, and I see no large pulmonary masses. I would like to look for pulmonary nodules in a bit more detail, and they would say, don't bother, right? And then you'd say, right, I'm going to now concentrate on the abdominal findings I described earlier. So I can see that there is air within the biliary system. This can be normal, particularly in this distribution if the patient has a prior biliary intervention, such as an ERCP and sphincterotomy. I don't see any abnormality beyond that. There's no obvious areas of persistent ductal dilatation. There is, however, also an area of low density I see within the right lobe of the liver in this distribution. Looking at this, and notwithstanding the fact that this is an arterial phase study, and so somewhat difficult to further evaluate, it does appear to be mass-like in its appearance. And in fact, it lies very close to the portal vein. So this is the main portal vein. This is the left portal vein, but the right portal vein is absent. And in fact, a lot of this here represents right-sided portal vein thrombosis. Again, super difficult to identify, but common, and a slightly atypical presentation of it. I would like to, and then, looking elsewhere within the rest of the upper abdomen as partially imaged, they would say, don't bother. And I'd say I'd also like to finish by looking at the bones, and they would say, don't bother. Then I would say, so in summary, now I did ask you your summary, and your summary was a bit too long. Try to keep your summary super succinct. Generally, with these cases, all of the relevant stuff will form in one nicely neated, packaged container. These are exam cases, not real life cases that exist, 10 a penny, that we all report day in, day out. So generally, try to keep your summary to maybe 3 or 4 sentences, no more than that. So a summary for a case like that would be, this is a thoracic CT with a patient with extensive emphysema, and supradiaphragmatic lymphadenopathy with an abnormal lesion within the right lobe of the liver and portal vein thrombosis. I suspect there may be a malignant underlying cause, and I'd recommend a portal venous scan through the abdomen and pelvis, and following that, review of this scan, potentially a referral to a relevant MD2. That's what I would say. Your point about prior imaging is very helpful as well. Good. Okay, let's try and get you to be able to scroll on this. So let's have another go.
Yes, sir. Now I am able to scroll.
Better? Super.
Yes, sir.
Okay, well done. So
yes, sir. So I just wanted to ask, in the last scan, there was no interstitial fibrosis in the lower lobes?
It was all severe emphysema.
Okay.
It was all severe emphysema. I think honeycombing can be overhauled, particularly when you've got quite extensive emphysematous change. One of the things that would push you towards interstitial fibrosis over just widespread emphysema is, number 1, volume loss, and number 2, tractional dilatation to the airways. That can be quite hard to differentiate between cystic airspace disease, like emphysema, or other cystic change, or cystic appearing. So if you want to call interstitial change, you really should have fibrotic tractional dilatation of the airways. And actually, when you looked at that on a MIP or a coronal, you didn't really have airway dilatation.
Okay, sir.
So let's go through this case. This is a gentleman who has presented with weight loss.
Okay. So I've been presented with axial post-contrast images, abdomen and pelvis of a patient who's presented with weight loss. I would quickly scroll till the last image before I start commenting. Okay. So on the initial scroll, I was not able to visualize any obvious abnormality. On the last scroll, I'm just able to visualize that there appears to be a hypoenhancing lesion within the right testes. But I would come back to the lesion. I would just scroll again to look for any other obvious abnormality within the abdomen. So I would like to systematically first go from the upper images. So I was able to visualize some heterogeneous area in the left lobe of liver. Uh, okay. I'm just trying to focus on the left lobe of liver again. Um, okay. Okay. So there appears to be few hypoenhancing areas noted within the segment 2 of liver. Uh, so actually the images are jumping a bit, so I'm not able to focus on one image. Yeah. So there appears to be a hypoenhancing area, heterogeneously enhancing area noted in the left lobe of liver. Uh, So I would look at the other phases and further comment on these after looking at other phases. Now I'd like to go at go and look at the other organs. So both the adrenals appear normal, spleen appears normal. There is no obvious lesion noted within the kidneys. Uh, Also, there appears to be some hypoenhancing areas noted within the uh, pancreas, but I would further look on the arterial phase because that would show the best enhancement of the pancreas. I'm going downwards to look for any retroperitoneal lymph nodes, which could be associated with the testicular mass. Uh,
Okay,
so,
let's get back up to the pancreas and focus on that for a while.
okay,
It's a
sure.
single portal venous phase examination. There's no arterial phase available.
Okay, so, okay. So I'm just going slowly till that phase because the images are jumping a bit. Yeah. So there is evidence of hypoenhancing areas, hypoenhancing ill-defined area noted in the body of pancreas. The main pancreatic duct appears distal in the distal body and tail region after this lesion. Uh, this lesion appears to be abutting the superior mesenteric vein, the portal vein confluence. I would also like to focus on the splenic vein to look for any thrombosis within. The lesion also appears to
Can,
be
can, can
lateral to
you can you show me the splenic vein?
so I'm just trying to look at the splenic vein. The medial portion of the splenic vein is not visualized.
Hmm.
So that could be thrombosed. Uh, there's no evidence of any thrombosis noted within the portal vein. However, the portal vein appears dilated. There also appears to be multiple collaterals noted in the peripancreatic region as well as in the perisplenic region. Uh, then the lesion that I described previously appears to be lateral to the superior mesenteric artery. Uh, uh, okay, this appears to be an aggressive pathology, appears to be neoplastic. Um, and the lesion within the liver could probably a metastatic deposit of the related to the lesion in the pancreas. I'm trying to look for any enlarged lymph nodes adjacent, which could be metastatic lymph nodes. Um, there is no evidence of any metastatic lymph nodes. There is no evidence of any calcification noted within the lesion of the pancreas. CBD also appears to be normal. It's not dilated. I'm just looking at the gallbladder. The gallbladder appears to be. There is also evidence of some hypoenhancing areas noted within the gallbladder. The gallbladder wall appears is minimally distended, but however, the gallbladder wall appears thickened with some pericholecystic uh, edema, which could be reactive because uh, yeah, I would like to trace the portal vein
Okay.
in
Would
its
you?
entire segment.
Thank you. Would you summarize the case for me, please?
So I was able to visualize an ill-defined lesion in the pancreas with thrombosis within the splenic vein as well as uh, some edema in the gallbladder. This is, and also a metastatic lesion within the liver. This appears to be a neoplastic etiology, like an adenocarcinoma of pancreas, because there's dilatation of the distal pancreatic duct. This needs to be further discussed in the hepatobiliary MDT for discussion regarding the biopsy. And also, I would like to do a staging CT of this patient. I would also like to look at the bone window images to look for any metastasis within the bone.
Good. Okay. So again, the summary is a little bit long, but much better, much better. Just a very small tweak on your summary. So it's more of a pet peeve than anything else, but don't refer to the MDT prior to getting imaging. So say you want full staging and discussion at the MDT. An MDT would find that scan an obvious pancreatic cancer, but they can't make any decision as a result of it until they have the cancer staging tap. So always say, I need further imaging, which is and MDT discussion. You may also say something like a CA19-9 for pancreatic cancer. So let's go through this case. Just keep your mouse still so I can take control of it. So you are right to point out this area here within the tail of the pancreas. So this is a large pancreatic cancer. I can't see the pancreatic duct. Maybe it's this. In fact, it probably is this as a dilated bit of pancreatic duct, but super difficult to see. I think what you're actually seeing more obviously as the malignancy is this large pancreatic tumor. Generally, when you're thinking about pancreatic cancers, what they do very well is obliterate local blood vessels. And by that, I mean they just more likely squash them rather than thrombose them, because they have quite a lot of local mass effect, pancreatic malignancies, but they do also cause a prothrombotic state. So they do also thrombose. So in this case, you're right to say the splenic vein is entirely obliterated by the primary tumor. Generally, when you're describing the primary tumor, it might be worth the way that you stage them is whether or not they have involvement of the arterial tree, not the venous system. So involvement or encasement of either the celiac axis or its branches or the superior mesenteric artery generally means it's irresectable. And would put you as a T4 tumor. But generally, it might be a good thing worth discussing or mentioning in a 2B Viva, talking about vessel involvement. So you identify the pancreatic tumor and you identified that there's some areas below it that appear discrete and separate from the primary tumor, concerning for local invasion or peritoneal disease. Actually, if you look, there's really quite widespread peritoneal disease. There's disease over here. The more you go down, the more you see. If you go down into the pelvis, there's quite a lot. These areas here will be peritoneal disease. There's another big blob of peritoneal or omental, that might be disease over there. And we've got a big plaque of peritoneal disease down in the pelvis, which is discrete from the bowel. So all this is disease. Coming back up, let's talk about the liver. There's another big chunk of disease down here somewhere. Here we are, in front of that loop of bowel. Coming up, looking at the liver. So you were right to describe this abnormality within the left lobe. By the way, note that I describe things more broadly as right lobe or left lobe. I think describing segments can be somewhat challenging in the midst of an exam. If it's very clearly a segment and you're comfortable describing segments accurately, then go ahead. If you're not sure, stick with right or left. And then if they ask and you can describe. The reason I have a describe caution with this is much like any description of anatomy by a radiologist, surgeons, if you work in a surgical center, will depend upon your description. So if you misclassify something as between a segment 8 and a 4A, that's a different type of surgical procedure they'll undertake. And so I'm quite fastidious and strict about segment naming for that reason. And getting it wrong, I think, has implications. But if you're comfortable doing it, go ahead and do it. If you'd rather go right and left, I think that's entirely reasonable in the context of an exam, but you ought to know how to accurately define the segments. So when I looked at this abnormality in the liver, to me, it looks like it's branching. Can you
Yes,
see
sir.
that?
Yes,
Yeah.
sir.
So when I see a branching low density thing in the liver, I think of two things: duct
Thrombus.
and vessel. Great. And it's thrombus, isn't it? Really, really well done. So duct or thrombus. And if I look, so you said there was no portal vein thrombus, and I agree, there's no main portal vein thrombus, but this is the right, this is left, and it suddenly just stops there. And all of this is thrombosed intrahepatic portal vein thrombus. And actually, you probably even have thrombus going down into that vessel as well. So probably not a metastatic deposit, probably an intrahepatic portal vein thrombus. So how would I summarize this? I would say the other thing I would say is when you summarize, try not to carry on scrolling as you do it. It's a small technique, and most people won't be fast, but allows you to concentrate. So I would summarize this as this is a CT abdomen and pelvis with a pancreatic mass within a body of the pancreas with local mass effect to the adjacent structures. There is widespread peritoneal disease and an intrahepatic portal vein thrombus. I suspect this represents disseminated pancreatic cancer. I'd request or suggest a CT chest, abdomen, and pelvis. I'd request or suggest a CT chest for staging purposes and discussion at the local MDT. The clinician may also wish to do a CA 19-9. That's it. I wouldn't go on to talk about PET-CT. I wouldn't go on to talk about MRIs, because in this case, MRI, completely useless. PET-CT, completely useless also. We know they've got metastatic disease. And so PET-CT is to look for metastases and to find any occult disease prior to consideration of surgery. If you know you've got metastases, you just need to stage of the chest for due diligence, and they will start systemic therapy. Good, well done. Last case for you.
Sir, I just wanted to ask, in this, the GB was normal, the gallbladder?
The gallbladder. Wouldn't call it normal, but it's not my main focus. I would probably think this is probably chronic cholecystitis. So chronic cholecystitis can look a bit, the gallbladder wall can look a bit fluffy, can look a bit irregular, but if you go down, there isn't really any pericholecystic inflammatory change. Look at the fat adjacent to that gallbladder, it's pristine. You don't get pericholecystic inflammatory change adjacent to some of the gallbladder and not the rest. Makes no sense pathologically, right?
Yes, sir.
So if you see really crisp fat lines around the gallbladder, but the gallbladder itself is a bit indistinct, generally you might say, oh, this might reflect chronic cholecystitis. But given the gallbladder is relatively collapsed at the time of imaging, I'd correlate with an ultrasound. Totally legitimate. Yeah.
Okay, sir. Thank you.
And in this case, if there was nothing else on the scan, you might make more of the gallbladder.
Yes, sir.
But the big striking abnormality here is the pancreas, right? Which you readily identified. So focus on the thing that's obvious and the bits around it. A concurrent gallbladder cancer with a pancreatic cancer, it's just too weird. So I wouldn't dismiss it, but I wouldn't focus on it. Okay. last case for you. You're doing very well. So this is a post-contrast CT abdomen and pelvis. Again, this patient is day 6 post-laparotomy for an acute colitis, and they're presenting with worsening inflammatory markers. Go ahead.
So I've been presented with axial post-contrast images. I would first initially scroll to the last image before I start commenting. Um, so this patient has had a laparotomy. So I'm going to the last image before I start commenting. So I can see that there was evidence of extra luminal intraperitoneal air just anterior to the liver, which was likely post-operative air, given the history of laparotomy. I can see that there are a few dilated bowel loops noted in the uh, uh, right hypochondriac, right lumbar region.
Mhm.
So I would just like to focus on that initially.
Don't
Uh,
worry about that.
okay, so I'm just scrolling again to the last image to look for any obvious other abnormality. Uh, okay, I can see that there was some contrast extravasation noted in the okay. There appears to be fluid noted in the pelvis with areas of peritoneal enhancement, which could suggest peritonitis, signs of peritonitis. There also appears to be thickening noted in the sigmoid colon. There are multiple diverticuli noted in the sigmoid colon. Uh, okay, so I'm just going down. There appears to be a hyper-enhancing area that I would like to trace the sigmoid colon. So the images are jumping a bit. So actually, I was trying to trace the sigmoid colon in its entirety because I was able to visualize some hyper-enhancing areas at the junction of sigmoid colon and descending uh, colon.
Okay.
So yes, yeah, there appears to be some surgical clips noted in this region. There is discontinuity of the bowel loops noted out here. Um, so I would initially first like to. There also appears to be a ileostomy noted in the right lumbar region. Uh, so I'm just trying to look again at the continuity of the sigmoid junction. Uh, there appears to be a hyper-enhancing area noted in the junction of sigmoid colon and uh, the descending colon, and there is discontinuity. So there is probably uh, some disruption of the sutures at this site, which could probably be the cause of increased abdominal discomfort at the present. At this point, I would initially first compare with the previous scan to look for what was the abnormality in the previous scan. And in this scan, I can see that there is adjacent significant fat stranding noted in this region. Also appears to be some air foci adjacent to this area. Um,
Okay.
yes. Uh, so there is
Do you,
significant ascites of fluid also noted adjacent in the left paracolic gutter.
okay.
Um,
Just summarize the case for me.
yes, sir. So I've been presented with post-contrast uh, axial abdomen images. I can see that there is discontinuity in the rectosigmoid, discontinuity noted in the region of the left iliac fossa region. The There also appears to be surgical clip in that. Uh, so this is the surgical emergency, and I would urgently pick up my phone and inform the surgical on-call team and let them know about the findings and would compare with the previous reports
Good.
about the.
Okay. So so I'm just going to move us on in just in view of time. So I think you picked up on some really interesting and made some good observations here. So The first thing you said was there's free intraperitoneal gas in keeping with surgery, which of course is true. But the free intraperitoneal gas is all over the place. By that, I mean it's in all four quadrants, right? There's free gas down here in the bottom left-hand side of the tummy, and there's free gas all the way up near the top in the left upper quadrant of the abdomen. Day 6, that there is no good data on how quickly gas should be absorbed post-operatively. Generally, it's thought that post-laparoscopy, gas absorbs much faster because typically they insert carbon dioxide in a laparoscopy. With a laparotomy, it's all air because they've just cut the patient open. So that's relatively evidence-based. But beyond that, it's not great. However, subjectively, this is more their air than you would expect 6 days post-laparotomy, subjectively. As a point of education, not necessarily as a point that you should pick up for the exam. But that makes me, as a GI radiologist, immediately question what's going on. The next thing I would say, as a really critical thing to do, is always understand what surgery the patient's had. So you did something that one of my old registrars did for this case, which is they said that this was a sigmoid anastomosis. But actually, where's the colon gone? If you remember the history, I said day 6 post-laparotomy for an acute colitis. Off the top of your head, do you know what surgery they'll do for an acute colitis?
Hemicolectomy.
They typically do a subtotal colectomy. So in this case, they brought out an endoleostomy. And what they do with the stump, the rectum, or the sigmoid, is they typically just oversew it. So they just sew it the end shut, and then anything that's in there and any mucus that will produce can come out the rectum. Sometimes you will see that what they do is, rather than oversew it and leave it in the abdomen, they'll oversew it and attach it to the anterior abdominal wall. Don't know if you've ever seen that. And typically the surgeons will do this when they're doing a hot subtotal colectomy. So patients who have a severe acute current colitis, toxic megacolon type patients, they'll chop out most of the colon, they'll oversew the rectum or sigmoid, but then they'll attach it to the anterior abdominal wall. So if it bursts anteriorly into the abdominal wall. They cut a bit of the anterior abdominal wall on, and they'll create a formed fistula. In this case, they haven't. In this case, they've oversewn the stump and dumped it back in the pelvis. And this is a disaster when this happens, because you can imagine in a patient who's got an acute colitis, those of you who've done surgery, when you're putting those, and I haven't, but when you're putting those sutures through that bowel, that's edematous, partially ischemic, the sutures just cheese wire through the bowel. It's very difficult to keep it closed, and it all just kind of falls apart. And that's what's happened here. So in this patient, you've got subtotal colectomy and endocolostomy. This is a sigmoid stump. Yeah.
Okay.
And
Yes,
as you rightly pointed out, you've gone from enhancement to non-enhancement, and you've got loads of gas, adjacent to it. So this is what's called a blown stump. You really accurately picked up the peritonitis. I was really impressed by that. So enhancing peripheral peritoneal margin, smooth peritonitis. Now, the only caveat I would say, day 6 post-laparotomy, you may very well end up with something that looks like a peritonitis. Not from, in this case, what is the blown stump and widespread sepsis, but actually just from what's called handled bowel. You could imagine, again, the surgeon's been in there jiggling things around. This patient's had colitis prior to the procedure, and so their peritoneum is going to be inflamed just because of the surgery that they've had. So just a caveat, but a really good observation. Brilliant, well done. Any quick questions before we move on to the next candidate?
No, sir. Thank you, sir. Amazing cases, sir. Thank you.
Well done. Okay, candidate 2, should we come back to you?
Yes, sir. Thank you so much for adjusting me. Thank you so much.
No worries. Hopefully you've got a mouse. Do you want to
Yes,
take control?
I have requested some.
Yep, it's just come through. Okay, you should have that now.
Oh, yeah.
Fantastic.
Yes.
Okay.
Yes. Perfect.
So this is a patient with new onset diabetes.
Right. This is CT abdomen, post contrast axial slices. I'll take a moment to scroll through the images and then would start presenting my findings. In my initial scroll, I can see there is significant abdominal fat. I could appreciate few renal cysts. This is the last cut. Okay,
That's the
this
last
is
cut.
probably, yeah, this is the last cut. So, yes, so I'll come back to the upper abdomen again. So the patient has got a recent diagnosed diabetes. Okay, the images are scrolling a bit faster. I can appreciate the imaging is done in angiographic phase. The liver parenchyma is not significantly enhancing. I'm trying to focus on the pancreatic parenchyma, where I could appreciate the pancreatic duct is mildly prominent. I'll take a moment to see all through the entire images of the pancreatic parenchyma to rule out any pancreatic parenchymal mass lesion.
Good. Would you like to, if I just take over your mouse very quickly,
Sure.
and here's the portal
Yes.
venous phase of the same patient.
Thank you. Do I need to request the control again for this?
No, you should be able to scroll it.
Yeah.
And if you just focus in on the pancreas again.
Yeah. So it's scrolling. Yeah. So I can appreciate there is some lobulated yeah. In the head of the pancreas, I can appreciate some lobulated alter density, alter enhancement area in this, but yes. In this region, in the C loop of the duodenum, with medial margins merging with the medial margin merging with the duodenum. However, proximally, the pancreatic duct does not appear to be dilated. I'm trying to scroll smoothly so that I can appreciate its true extent. Yeah, the pancreatic duct is dilated. Pancreatic duct is dilated. Pancreatic parenchyma appears to be atrophic without any calcification, without any other cystic lesion within the pancreas, no peripancreatic stranding. I'll be coming back again towards the region of the pancreatic head. Yeah. Yes, so this area appears to be a bit lobulated, bulky for the rest of the pancreatic parenchyma. In my actual practice, I would window the region a bit to make it more apparent. It is causing pancreatic ductal dilatation. I'm looking at the biliary duct now, which also appears to be prominent in this section. However, I can also appear surgical clips in the gallbladder fossa, so that can be compensatory dilatation. But I would still like to confirm it by correlating my finding with the LFTs if they are obstructing or not. For the rest of the liver parenchyma, I would like to look for any hepatic parenchymal lesions, which I cannot clearly appreciate. No, yes. Now it focus on the regions of gastrohepatic recess and celiac axis to rule out presence of any lymphadenopathy, which I cannot clearly appreciate any significant lymphadenopathy. In my routine practice, I'll be looking at rest of the organs and peritoneum to rule out any peritoneal lesions. The stomach wall also appears to be a bit thickened, but it is also collapsed. It is more prominent in the fundal and in the region of the body and fundus, but it's smooth and without any I cannot appreciate any significant rugal folds of the stomach, so I would be concerned and I would like to probe for any history of stomach related problems. Since the patient has come with recent onset of diabetes, I would like to check for this pancreatic lesion. I would be concerned for pancreatic neuroendocrine tumor, which I would be looking at the arterial phase to look for it in enhancement since it's hypervascular, but there isn't any related liver parenchymal lesion. I would also like to check for any relevant tumor markers in this patient. And for completion, I would like to look at the bones as well as the chest, lung windows if available. And the patient needs to be discussed and further referred to the hepatobiliary MDT for further management and discussion.
Good. Can you just, on this slice here, just point to me where you perceive the potential malignancy to be? It might not be on that slice.
Yeah. Okay, now I remember this word. So I could appreciate the pancreatic. So this area, this one, it
Okay.
looked a bit bulky to me as compared to the rest of the parenchyma. Plus, there is another hypoenhancing area in the body and tail region, junction of body and tail.
Show me that.
It was rather smaller, but it is giving some cutoff to the pancreatic duct, distal to which the proximal to which the pancreatic duct is dilated again, but it was also causing some disruption. This one.
Good. Okay. Right. Let me take over the mouse again.
Yeah.
Very well done. So I gave you an arterial phase examination and an portal venous phase. This is a very common indication, specifically in the UK, but it's reasonable to have this abroad and overseas as well. Patient with new onset diabetes or sudden acute worsening of handling of diabetes, consider a CT pancreas to look for pancreatic malignancy. Not specifically neuroendocrine, so these are not glucagonomas or insulinomas. Actually, a bog standard pancreatic adenocarcinoma will result in quite a significant change to diabetes controls or new onset diabetes. So the arterial phase wasn't particularly telling, other than to say that you could just about see that the duct was up here, and the duct wasn't really up in the rest of the pancreas. To my point earlier, this is a vascular phase or an angiographic phase, as you described this arterial study. So you can see the pancreas should be brighter, shouldn't it, on this phase if it was a true parenchymal phase. is not that enhanced, and the pancreas is a very arterialized organ. So we do not have contrast in the portal vein yet, and as a result, I would say this is an early arterial phase study. So if I were in an MDT, and if I were to say, be asked the question, are there any arterially enhancing lesions within the liver to suggest these are neuroendocrine metastases? I would say this is not a suitable study to exclude this on. It's done too early. What nuclear medicine scan would I do if I'm looking for neuroendocrine tumor? Do you know?
Is it the DOTA scan?
Yeah, great. Gallium dotatate PET would be what I would use as first line. Well done. So this is the abnormality here. It's subtle, isn't it?
Yeah.
And this is one of the things I would say, right? This is a typical presentation of a typical thing, but it's an important thing. And these pancreatic cancers can be subtle. So what makes me think that there's a pancreatic tumor here? The one and only thing that makes me look at that abnormality more than anything else is this duct. The duct is focally dilated here in the tail, and really not the same level of dilated up here. It is substantially more dilated distally, isn't it? Whenever you see that difference, there has to be something in the middle causing there to be a difference, and broadly that will always be tumor until proven otherwise. And so as you scroll, and maybe if you window, you will suddenly see this very ill-defined area here. That is a pancreatic tumor. Don't know if it's adenocarcinoma, don't know if it's neuroendocrine, don't know if it's what it is, probably an adeno, but I don't know at this stage. So once I've spotted that, then I would go on to I've spotted or maybe I'll just present it, right? So this is an arterial CT scan through the upper abdomen. Looking through, I see no obvious abnormality in the liver, apart from a small arterially enhancing focus within the right lobe. The adrenals look normal, the liver looks normal, the spleen looks unremarkable in arterial phase. There's a few small cysts within the kidneys, pardon me. And within the pancreas, I suspect there might be some ductal dilatation within the tail, although the scan is not particularly well timed for a parenchymal arterial phase. Looking at the portal venous phase examination, and in particular focusing in on that abnormality within the pancreas, it does appear that there's an ill-defined, maybe 1 to 2 centimeter mass within the tail of the pancreas, with evidence of distal obstruction, as evidenced by the mild pancreatic duct dilatation distally. I don't see any evidence that there's invasion to the local vascular structures. I see no evidence of local lymphadenopathy either within the peripancreatic, hepatoportal, left gastric, or perihiatal distribution. I see no vascular thrombosis. Looking at the liver, I see no evidence of metastases, that small arterialized focus. I can't see on this portal venous phase study, and is indeterminate, but probably benign, and this may require further follow-up according to MDT discussion. I'm looking for peritoneal disease, given that pancreatic cancers can result in peritoneal deposits. I'm looking at other structures to make sure there's no disease. I'd like to look at the bones, they'd say no. I'd like to look at the lung bases for pulmonary nodules, they'd say no. And I'd recommend referral to the MDT, completion of staging, referral to MDT, consideration of an ACA 19.9. You raised the concept of a thickened stomach wall. And actually, I think for most general radiologists, they would also raise that as a concern. I think that's reasonable as a raise. Just a tip, if you see gas locules peripherally in what it looks like a thickened wall, it's just collapsed rugal folds. Think about it. Pathologically, if this was all tumor, why on earth would you have a gas locule this far out?
Right, sir.
And the more you see of these peripheral blobs of air, the more you can be convinced, actually, you know what, this is just collapsed rugal fault. And of course, what you did was completely reasonable, right? I'd just like to correlate this with any gastrointestinal symptoms. And if I was concerned, I'd recommend an endoscopy. Again, just from an educational perspective, if you are concerned, what would you could be concerned about if this was thickened, diffuse gastric thickening? What's the word?
So the parents is more in favor of rhinitis. So patient
Good.
would be having definitely some symptoms.
Good. So rhinitis plastica is
Yeah.
what you're raising a concern of. Now, as an educational point, endoscopically, rhinitis plastica is actually quite difficult to diagnose. You put the endoscope down, the gastric mucosa looks pretty normal.
Yeah.
But what they need to test for specifically is distensibility. So if you ever see something that you're worried about being rhinitis, you have to explicitly say in your report, recommend an endoscopy and specifically look for distensibility to rule out rhinitis. Don't just say recommend an endoscopy, because someone will go in, look at the gastric mucosa, say it's all normal, take a couple of biopsies. The biopsies may be normal because they're mucosal. They might be shallow.
Amazing.
And I've seen plenty of cases of rhinitis missed on endoscopy, seen on imaging, and we've got to push for a repeat endoscopy. And when they take deep biopsies, they'll find a bit of cancer.
Right.
Good. Okay, let's move on to the next case.
And so sorry, can I please ask the Leon that I was assuming that there is in the head, it was a normal parenchyma. It was not a lesion in there?
Normal.
Yeah, okay.
No, normal.
Okay, thank you.
Okay. This is a patient who presented with an accident emergency with abdominal pain, query cause.
Do I, okay, no, it's okay. I'm sorry, I missed the history part because of scrolling. So it's patient has presented in emergency.
With abdominal pain.
With abdominal pain. So I've been presented with CT abdomen and portovenous phase. I'll take a moment to scroll through the images and then would start presenting my findings. In my initial scroll, I could appreciate there was a small area of lingular collapse on the left side. There are few liver hypodense lesions and a pancreatic and aortocaval and retropancreatic lesion, which I would come to later after completing my initial scrolling. So renal parenchymas grossly appear normal. There is not any gross, mild pelvic ascites is seen, but there is no gross ascites. And I cannot appreciate any growing hernias and no visible scrotal masses in this male patient. So I'll quickly go to the same area of interest in the upper abdomen. Meanwhile, I'm looking at the vessels also to rule out any vascular pathology. There is some stranding noted in the right hemiabdomen. So there was stranding in that. Okay. So there are areas of there is an area of lobulated centrally hypo-enhancing lobulated mass lesion in the at porta hepatis along the celiac axis. I'm trying to delineate it from the pancreatic parenchyma and trying to look for its origin exactly. It is lying interior to the inferior vena infrahepatic part of IVC. The portal vein is passing through anterior part of this mass, which is causing its compression, but no definitive portal vein thrombosis could be appreciated. There are multiple centrally necrotic, peripherally enhancing bilobar liver lesions involving both lobes with lobulated margins and without any surrounding parenchymal edema. No hepatic vein or portal vein thrombosis is appreciated. Adrenal glands appear normal. Spleen appears unremarkable. So I'll now going to the area of right hemiabdomen where I could appreciate some pericolonic stranding. Considering that they are hepatic lesions, I would like to rule out bowel-related pathology. So I'm in the region of ascending colon as well as transverse colon appear normal. This is, I can appreciate the ileocecal ileum and ileocecal junction appears normal. I'm trying to focus on the cecal wall. I would also like to cross-check my findings on the coronal views, but the cecal wall definitely appears thickened. This is the appendix. I would also like to check this finding on the coronal sequence. There's significant pericecal fat stranding. However, the vessels leading to the cecum appears to be contrast opacified without any vascular thrombus.
Okay, if you could summarize your findings so far, please.
This, since I feel this is an old age patient, I could appreciate atherosclerotic changes. This appears to be a cecal pathology with liver lesions as well as nodal metastasis. I would like to complete my study by looking at the bones as well as the lungs. That would include my staging as well. The patient needs, since there are no proximal bowel obstruction at the moment, the findings can be discussed with the referring team, and patient needs to be discussed with lower GI MDT for biopsy sampling and further management after the completion CT staging has been done.
Good. Right, I'll take over the mouse. Great job. Well done. Really well done. So let me walk you through the findings. Multifocal, bilobar, ill-defined, heterogeneous liver lesions. There's nothing else that these are other than metastases. You were clear about that, and I think that's totally reasonable to be. Okay, these are multifocal bilobar metastases. There's a big old mass in the kind of peripancreatic hepatic portal area, necrotic, large lymph nodal mass. Now, what people typically, the trap that some people typically fall into is called this pancreatic. This is a pancreatic tumor with metastases. And in this scenario, it's not. And it's not because I showed you a tiny pancreatic cancer, didn't I, just a little while ago?
Sure.
And it caused a lot of mass effect. And I told you on that first pancreatic case that pancreatic tumors typically cause a lot of adjacent mass effect. They crush vessels, they cause ductal dilatation. They're quite a massive, hard tumor. If this was a pancreatic tumor, it's big, but look, portal vein is narrowed, but it's still patent. The pancreatic duct is not dilated. And so you were so right in not calling this pancreas. You're absolutely right. This is not pancreatic. This is just big old peripancreatic, periportal lymphadenopathy, necrotic. And that distribution made you think about colorectal, and I think very sensible. So this is where I think it became a bit challenging. So let's look at the bowel. So this here, there is the ileocecal valve. That bit, that bit. Yeah, do you see that?
Sir.
That's the ileocecal valve. So again, you go one way, you'll end up with something. You'll go another way, you'll end up with to go one way, you get cecum. You go the other way, you get to ascending colon. This patient's bowel is a little bit malrotated. So in this case, this is ileocecal valve. This bit here is cecum. This bit here is ascending colon. Now, what's in that colon?
Air fluid levels, obstruction? No.
Yeah, low-grade obstruction.
Mm.
So let's carry on going up the ascending colon. Can you see? Look at the wall here. Look at the color of it.
Yeah.
Now look at the wall here. Look at the color of it. Do you see? It's focally enhancing before going off to transverse colon.
Yes, sir.
Now, one thing colorectal cancers do is enhance. On a portal venous phase study, they nearly always slightly hyper-enhance compared to the adjacent bowel. Spasm doesn't do that. Cancers do. Now, there's broadly two types of cancers that you see. These kind of mass-forming apple core, big stricture, fleshy things. The other type, more unusual, is this sclerotic type, where it kind of just narrows down and it causes these strictures without any real mass effect. Typically, they occur near the splenic flexure. It's a subtype. Typically, they're also pretty aggressive. This one's in a bit of a funny location and is actually in the kind of mid-transverse hepatic flexure, given everything's all in a bit of a funny location, but it's here. And you see the upstream bowel is mildly dilated. And you can see there's an air fluid level in the terminal ileum. This patient actually presented a week later with subacute obstruction. So they weren't obstructed on this scan, but a week later they presented obstructed. The other thing I just want you to note on this scan, and again as a point of education, always when you're looking at colorectal cancers, look to see where it is in relation to the duodenum. So for right-sided colon cancers, they will do typically a right hemicolectomy. They will surgically go up the mesentery on the right, and depending upon the skill level of the surgeon and where the highest node of involvement is, they will resect up the mesentery. Now, as they go up the mesentery, they end up in what some my local surgeons refer to as tiger country, which is the duodenum, the pancreatic head, and all of these central mesenteric vessels, which they try to avoid like the plague. Now, one of the things that they always want to know is how far is the tumor from the duodenum? And sometimes it's well away and it's obvious. Don't worry about it. But always worth just checking, is the cancer anywhere near the duodenum? Because if it is, like this is, there is a fair chance the duodenum is involved. And it makes it very difficult to resect, to the point of they probably wouldn't resect it. Clearly, in this case, there's widespread disseminated metastatic disease at this point, right? You've described that. Now, that doesn't mean that it's not resectable. Colorectal cancer is treated in very different ways, particularly in the UK. We treat it more like an oligometastatic disease. So we'll happily chop out the primary and carry on chopping out the metastases as they form. Unlike some cancers where as soon as it's metastatic, your only hope is chemotherapy. But typically, this patient like this would end up with systemic chemotherapy and then a review at the MDT.
So the point of distance from duodenum you have told only for the right-sided colonic cancer, not for the left-sided ones.
Typically,
Yeah,
yes,
okay.
because the left-sided ones, the mesentery doesn't come into that same place. Typically, in right-sided tumors, right-sided tumors typically invade the duodenum. The left sides don't.
Right, sir. Thank you.
Okay. Last case. This is an urgent inpatient scan. Patient has known cirrhosis and is rapidly dropping their hemoglobin. Query cause.
So this is a CT abdomen and pelvis in portovenous phase. I can appreciate the liver is significantly cirrhotic with a gross amount of ascites. I'll take a moment to scroll through the rest of the images and then would again come to the point of interest. So in the pelvis also, I can appreciate a dense level of ascites. This can represent hematocrit level. Since the patient is also patient has also presented with rapidly dropping HB, so I'll be highly concerned for this part to be representing a hemoperitoneum. In my scroll, I could appreciate changes in the left hip joint. I'll come to that later as well. There is gross amount of subcutaneous edema. I'll try to look for, since the patient is a known case of cirrhosis, I would like to initially check out if there is any liver lesion or HCC that has probably the cause of the pathology. I can appreciate the liver is heterogeneously enhancing in this phase. Predominantly the right lobe, the left lobe and the segment 4 appears unremarkable. I cannot appreciate in this portovenous phase, I cannot appreciate any significant contrast extravasation. Ideally, I should be looking at the arterial phase to look for any liver lesion and extra contrast extravasation from the liver on any ruptured lesion from there, if that's available. But since there is a lot of hematocrit level in the pelvis, that would be my top concern in this patient.
What would you do?
Since the patient is rapidly deteriorating, I'll discuss my findings with the referring physician. I would check any prior images, if available, to check if the patient is known to have any subcapsular HCC. If that's the case, then my top concern would be a ruptured HCC. In that case, I'll immediately inform the interventional radiology team, and instead of going for a triphasic scan, we can arrange a DSA, angiographic imaging, and embolization can be done there and then for this patient to save him, because actively bleeding tumor can the active bleeding needs to be controlled in this patient.
How often have you seen a ruptured HCC causing hemoperitoneum?
It's less common, but since I'll confirm that on prior images as well. If the patient is not known to have any HCC, then that is, of course, not possible in this case. Then in that case, I'll be exploring other reasons for this hemoperitoneum.
Good. Okay. All right, let me take over the mouse. Well done. I've actually only ever seen it happen twice. A ruptured HCC resulting in massive hemoperitoneum. And I've been at a large hepatobiliary centre for just over 10 years. It's not terribly common, certainly in the UK, but of course possible. It's a good shout. Without looking at the scan, what's the most common cause of a low HB in a patient with cirrhosis?
Cirrhosis itself can be a cause of HB, but acute drop means, acute drop was concerning in this patient, plus hemoperitoneum.
But forgetting this patient, what's the most common cause of a rapidly dropping hemoglobin in a patient with cirrhosis?
Cirrhosis itself, the liver
Yeah.
disease itself.
No, it's not. Cirrhosis itself will typically cause an anemia of chronic disease, a rapidly dropping
Rapidly
hemoglobin.
dropping. I'm
Go
sorry.
back to your ward days.
Yeah.
A variceal bleed, right? A GI,
Oh, yeah.
gastrointestinal bleed from varices.
Yeah.
So let's just look for that. Are there varices?
Yes, esophageal varices are there.
Good.
Esophageal and paraesophageal.
What's in the stomach?
Yes. That's
Now,
the active point. Oh gosh.
but does that explain the hemoperitoneum?
No.
It does not. So can you have high density stuff in the stomach that's not blood?
Yes, if it's
Food, tablets, all sorts of stuff cause high density stuff in the stomach,
yeah.
right? But look what's around it. Look at this density of the liquid around it in the stomach. It's probably blood, isn't it?
Yes, the stomach density is higher than the rest of the fluid, like rest of the ascites.
Correct. So I think they're having a variceal bleed. Number one. That does not explain the hemoperitoneum. In no way does intraluminal blood explain hemoperitoneum. So let's go down. You were so right. Spot on. Well done. This is ascites. The patient's got cirrhosis. Of course they'll have ascites, right? But as you went down, you noticed this big blob in the pelvis. This big blob, you are 100% correct, is a large volume of hemoperitoneum. Now, the mistake that one of my colleagues made was they said this is in the bladder. And they said someone put the catheter in and has caused a bleed from the bladder. No, this is not bladder.
Bladder is catheterized.
Bladder is catheterized down here. This is pelvic. But look at this anterior abdominal wall.
There is left
look
rectus
at-
teeth. Yeah.
Look at that. There's your
It's
blood.
probably from the left inferior epigastric.
And why have they bled suddenly from their left inferior epigastric?
Have they tried to do the tapping or drain placement?
Very good. They've tried to put a drain in to drain the ascites. They've hit the left inferior epigastric, and the patient has bled into their peritoneum. Very good. Well done. Okay. Next candidate, please. I'm sorry, we're running a bit behind, but I will give the next candidate the same amount of time as everyone else. And do you want to just take over mouse control, please?
Yes, I'm requesting the remote control.
Yeah, super. Okay, go ahead. You should be able to take control now.
Yeah, I have.
Wonderful. So this is a 38-year-old female who's presented with an acute abdomen, severely raised inflammatory markers.
Okay, so these are the axial post-contrast images of an abdomen, portovenous phase of an abdomen. The patient is presented with a complaint of acute abdomen. I will have a quick look through the whole set of the images before I comment my findings. So I'm going just to look through the images first before I comment my findings. I'm just going to the last cut. Okay, so I can see there is very fluid noted within the abdomen and pelvis. There is a the bowel loops appears to be collapsed. There are multiple, I think enlarged lymph nodes are seen within the mesentery. Apart from that, liver appears to be enlarged in size. So I'm going systematically as I could not find obvious abnormality. So liver appears to be enlarged in size and the spleen appears normal. And the portal vein appears normal, no any evidence of thrombosis within the portal vein. I'm looking at the pancreas. So the pancreas appears normal. I could not find any lesion within the pancreas. Pancreatic duct is slightly prominent. Looking at the bowel, the stomach appears normal, no any mass lesion seen within the stomach. The gallbladder is also appears normal. Looking at the kidneys, both kidneys are also appears normal.
Just scroll down to the pelvis for a
Okay,
bit.
so I'm going to the pelvis. There is a mesenteric fat staining is also present with mesenteric congestion, and I can see there is an cystic area noted within the left side of the pelvis.
Talk to me about that a bit more.
It appears to be in a biloculated with adjacent free fluid within the pelvis. I'm trying to see whether it is connected to the bowel loop or it is adnexal in origin.
If you like, there's a coronal that I can show you if that would help you.
Yes, I would like to see the coronal, please.
Okay, I'll just take over the mouse very briefly.
Mhm.
Oops. There you are, coronal for you.
So I have been presented with the coronal images of the same patient. I'm just looking to the area of concern. So I can see there is no low attenuation lesion with some peripheral enhancement seen on the left side. I'm trying to um, see its communication, um, whether it is arising from the. So the I think this seems to be this could be related to some ovarian, as patient is present with the acute abdomen, could be related to a tubo ovarian
Mhm.
abscess. Other possibility for this, uh, okay, so I can see this is seems to be connected to the. So this could be a dilated fallopian tube.
Good. Can you
Uh,
summarize your findings, please?
So yeah, so in summary, so I can see there is an lesion, like biloculated lesion seen within the left side of the pelvis. It is closely abutting the uterus and adjacent bowel loop. So the differential for this could be due to some tubo-ovarian abscess or could be um, related to bowel loops like diverticulum or Michel's diverticulum. But for this, I would like to review the previous imaging of the patient and also previous history of the patient, correlate with the ultrasound finding. And as patient is present with acute symptoms, so this required
Recording stopped. Recording in progress.
Sorry, carry on.
so this patient required urgent management for this.
Good. Okay, well done. So you were spot on. How would I have presented it slightly differently? I think I would have described it a bit more. And I actually don't think it is bilobed. Have you heard of the term serpiginous?
Yeah, yes.
I quite like the phrase serpiginous. It means serpent-like. Tubular is another word for it. But I
Okay.
think this is serpiginous. If you kind of go through it, it's definitely not two cysts. It is a tubular structure. Now that really kind of points you towards one of two things: bowel or fallopian tube, or appendix. Actually, it's the other thing I think it could be, or something like a Meckel's. It actually doesn't really point you to two things. It points you to many things, but it helps you stop saying it's something like an ovary, because ovaries are not tube-like. Um, I think I would have said something along the lines of, um, there is a slightly hyper-enhancing tubular structure within the left side of the pelvis with predominantly cystic fluid density internal contents. I'm struggling to see if this connects to the bowel, given the fact there's a generalized paucity of intra-abdominal fat. In view of that, I'm trying to identify if I can see the left ovary separately. I'm trying to see if the gonadal veins run into this structure, which might point me more towards suggesting it's fallopian in origin. I'll look to see if there are other small bowel loops that look similarly abnormal. And on the basis that there are no other small bowel loops that look similarly abnormal, on the basis that its location, I think this is probably tubovarian. Now, you talked about mesenteric stranding, and I think there's more than that. Look at these. There is a paucity of fat, but there's a segment here right in the anterior abdomen. All of this should be black, shouldn't it?
Yes.
Yeah, it's not. It's stranded. And this patient has peritonitis. The tubovarian abscesses, generally anything tubal is kind of open to the peritoneal space. So these patients get peritonitis quicker. And so all of this kind of additional gray, it's not all just paucity of intra-abdominal fat and lack of fat and lots of bowel loops together. There's additional gray here, which is stranding in a fluid, which you rightly picked up on, and probably is peritonitis. Good, well done. Okay, next case, so tubovarian abscess. Case 2. Feel free to scroll. This
Yeah.
is an outpatient scan. Tummy pain, query calls.
Sorry, I didn't get it.
Abdominal pain, query calls.
Okay. So these are the axial cuts of an abdomen, portovenous phase of a patient. The patient is having abdominal pain. I've just quick look through the whole set of the images before I comment my findings. So I'm just quickly going to the last cut just to have a look. So I'm looking at the images first and just quickly going to the last cut before I comment my findings. I could not find a significant free fluid within the abdomen. I'm looking at the bowel loops. So I can see there are enhancing lesion seen within the small bowel loops. So I have spotted the one. I'm just looking to the rest of the bowel loop if this is a single or this is a multiple. However, it is not causing proximal bowel loop dilatation. I'm looking at the rest of the bowel loops. Okay. So there is another enhancing lesion seen. I'm trying to see whether it is a vessel or it is within the bowel loop. So this appears to be within the mesentery. enhancing
What's your
lesion.
what's your differential for this appearance?
So it is an enhancing lesion within the mesentery, though I could not find any significant adjacent fat stranding or any kind of or like like
Sorry, I meant what's your differential for this whole case? Summarize the case for me.
okay, so there's enhancing lesion within the mesentery and the enhancing lesion within the small bowel loop. Given the significant enhancement, the differential for this one could be any carcinoid or which is present in the bowel loop and also in the mesentery. Other differential for this could be a metastasis if patient have any previous malignancy. Other differential for this could be for small bowel gist can be a possibility, but the lesion in the mesentery is least likely. So I will convey my finding to the referring physician. Also look at the, so there was no mets within the liver, and so this patient required referral to the referral to the hepatobiliary MDT. So it's GI-MDT, and for further discussion about the biopsy, and also as I'm thinking of carcinoid, so I would also recommend octreotide scan or rotated scan for further evaluation.
Um, what? No, let's leave it there. Exceptional, exceptional. Really well done for seeing that. It's not easy. I think the human eye does not look inside the bowel. We typically don't. So well done for finding it, and then well done for finding the node in the adjacent mesentery. Strong differential. You said carcinoid, you said metastasis, you said gist. What type of metastasis might you see that would cause this type of appearance?
I think melanoma mets or
Exceptional. Stop. Melanoma. Bloody brilliant. Really well done. I fully agree. A melanoma metastasis would look something similar to that. And a good plan of action. Very well done. Don't refer it to the hepatobiliary MDT. I know you
yeah, sorry.
corrected yourself, but I'd be miffed if I saw that in my meeting. Very well done. Okay, last case. This is an acute abdomen. Patients presented with vomiting.
Okay, so these are the, I have been presented with axial CT images of an abdomen. I'm just going to the, I'm starting from the top slices. Shall I start from the chest images, right?
You can just start there and work your way down. Correct.
Okay, so I'm looking through the images. The patient is presented with a complaint of acute abdomen. These are portovenous phase. I will just have a quick look through the whole set of the images before I comment my findings. I'm just going to see the images first. So as scrolling, I could find a significant mesenteric fat stranding within the abdomen. Okay, so I can see the bowel loops are appears to be mildly dilated, and I could find a hyperdense lesion within the, sorry, hyperdense foci within the bowel loop. This could be ileal bowel loops. And the bowel loops proximal to this area appears to be dilated.
Mhm.
And there's free fluid is also present within these bowel loops, and their bowel loops are small bowel loops. They are dilated, and so the jejunal loops are also appears to be dilated. And I could find the lesion in the left kidney, but I will come back to this lesion. I'm just trying to see. Okay, so the gallbladder, I'm looking at the gallbladder. Liver appears to be normal, no lesion seen within the liver. So gallbladder appears to be in a collapsed with, I think, internal focal of air with, I think there is a coloduodenal, the duodenal. There is fistulous communication between the gallbladder and the duodenum at this area.
Okay.
So this is suggestive of I think this is the high density which I saw on the small bowel, which is suggestive of gallstone, which have migrated through this fistulous communication between the gallbladder and the duodenum and causing a proximal bowel loop dilatation. And apart from that, the lesion which I saw in the kidney on the left side, which appears to be slightly concerning, as it is a hyperdense exophytic with internal hypodense area, and the lesion appears to be enhancing. So I'm worried about this lesion. This could be a malignant lesion. I'm looking on the adjacent if there is any large lymph nodes, which I could not find, and also looking at the IVC and renal vein to see if there is any thrombosis, which is not present in this case. For this, as I'm thinking this could be a renal cell carcinoma, so I would like to see the lung window to see if there's any metastasis, and also the bone window to see the metastasis. And in summary, so this is a case of gallstone ileus, and also left renal cell carcinoma, I'm thinking. So this require for gallstone, this require urgent surgical referral and management. And for RCC, I would like to see the previous imaging of the patient, if any previous workup has been done. If not, then I would recommend staging. As I can see, the chest images are also present, so I would see the chest and bone window images. If there is no metastasis, this requires referral to the GIMDT for further discussion and management.
Okay, good. When you're looking at small bowel obstruction, what must you look for?
Small bowel, proximal bowel loop dilatation,
So you're looking for
transition point,
dilatation. Sorry, dilatation,
and transition point.
a transition point. So you're looking to determine if it's mechanical or non-mechanical. Okay, what else?
If they are perforated or ischemia within the.
Right. So you look to see the cause of the small bowel obstruction first, and then you must always look to identify the sequelae of the small bowel obstruction. Have they perforated? Are they ischemic? Are they do they show any signs of what I call bowel compromise? Okay. Really important that you always do that. So absolutely right, spot on. Gallstone ileus, classic case. As soon as you see something, as soon as you see a colidocal duodenal fistula like this, big old tract, straight away just scroll down and start looking for a gallstone, especially if there's dilated bowel loops. Now, a couple of tips for gallstone ileus. Remember, the gallstone is not always calcified. So, gallstones, when you see them in the gallbladder, sometimes you can't see them. Agreed?
Yes, yeah.
On CT. So sometimes a migrated gallstone ileus, you will not see the gallstone on CT, but what you will see is a very sudden transition. Big to very little. And actually what you've got in the junction of the big is a gallstone. It's just very difficult to make out. Okay, so don't be fooled if you do not see a calcified gallstone. Non-calcified gallstones also exist and can be a contributory cause to a gallstone ileus that you don't necessarily see as obviously on CT. Now, with regards to the small bowel, what I hoped you'd have seen in addition is this loop here. Can you see how this is thickened?
Yes.
Yeah, and there's that locule of gas there.
Okay, yes.
Yeah, in the wall. Now, as the gallstone has passed through, well, either two things has happened, don't know. Either the gallstone has passed through and intermittently damaged the bowel wall as it's gone through, gotten stuck, lots of peristalsis against it, damaged the bowel wall and managed to get through, but left a bit of damaged bowel. Or this patient has had small bowel obstruction secondary to the gallstone to such a degree that they are now compromising their bowel. And that's what I mean by always look for ischemia, always look for perforation, always look for any kind of what I call compromise. Now,
Yes.
do you see, I'm trying to find a nice example of it. It's not terribly good, but oh, here we are. Do you see? So free fluid in the presence of small bowel obstruction generally is a negative sign. It generally means the bowel is unhappy. Not quite frankly ischemic, not enough to push you to a surgeon for surgery, but generally it's not a good prognostic sign.
Yes. Okay.
Generalized free fluid. But this thing called interloop free fluid, do you see this triangle of water here?
Yeah.
These are locules of fluid within the mesenteric leaves. And that's said to be an even more prognostically important sign of compromise. So interloop free fluid is actually more of it like that. Triangles of fluid is also generally not a good prognostic marker. This bowel here, I would refer to as compromised. It's thick-walled. It's edematous. So bowel is beautiful. Bowel's my favorite thing in GI because it's so predictable. But you've got a thin mucosal stripe, that enhancing bit. Everything low density and deep to the stripe is submucosa. And in this case, the submucosa is edematous, right? It's super low density and thick-walled. So this is submucosal edema. This here should not have gas here because this is the mucosal stripe. So this might be a deep ulcer. I wouldn't necessarily say this is pneumatosis. There's only one locule, but this might be a deep ulcer, probably caused from damage by the gallstone. Again, not necessarily going to precipitate surgery, but enough to say to the surgeon, hey, look, this patient's got gallstone ileus. It's a mechanical obstruction. You're probably going to need to fish that gallstone out. And what they do is they do a small enterotomy, which is a little cut in a bowel, take the gallstone out and suture it up together. But you might just want to walk the bowel proximal to it and make sure there's no small hole in a bit of bowel upstream. Yeah. So because you're telling them there's something dodgy slightly above. And if you can, even try and give them an estimate of how high it is above the gallstone. And it just helps the surgeon find those little things that might just make a difference and stop the patient coming back post-operatively with another hole.
Yes.
Yeah? Good. Well done. We're all done.
Also, about the left kidney lesion was.
Yeah, big old renal cell carcinoma. Incidental entirely. But as most renal cell carcinomas are, diagnosed incidentally.
Yes.
So yeah, it was an interesting side, but not the thing I was focusing on.
Thank you, sir.
Not at all. We're all finished.